Now we have Professor Namrata Sharma. She's going to take us through the enhancement, post-surgical enhancement after premium IOLs, because we talked about, a little bit of a residual refractive error, little bit of cylinder remaining. These premium IOL patients are never happy. So these are patients, they demand it has to be corrected, it has to be solved. So we listen to Professor Namrata Sharma. She's going to take us through that.
Thank you, sir, and thank you for making me a part of this course. I would be talking to you about post-surgical enhancement after premium intraocular lens implantation. There might be some overlap because some of the problems may be there also in non-premium IOL implantation. There are no financial disclosures, and we have, as far as the IOLs are concerned, evolved and right from 1950 until now, where it continues to evolve. And it evolves mainly because our requirements have been changing over the past few years. But I think, like it has been emphasized earlier, the patient expectations is very important. Sometimes after these premium IOL implantation, even when the results are less than perfect, the patients may not be bothered by it, and sometimes they may be bothered by it when they may seek you. There are cases at risk where these residual problems may occur, and this can occur because of inaccurate biometry, especially post-LASIK or in high myopia or high preoperative astigmatism, or pre-existing high-order abrasions which have been missed, or because of even ocular surface disorders, unrealistic patient expectations, or sometimes when there is a IOL tilt due to zonular dialysis or large capsular bag, or there are events such as trauma, etc. So decision to proceed with enhancement would depend. I think the most important thing is the level of satisfaction of the patient. So if the patient doesn't want it, then of course we don't do it. But also important is the fact that what are the potential benefits and risks of a second procedure, and obviously the most important for the patient point of view is additional cost of enhancement if there is any. Understanding the patient expectation is important, and also understanding the current situation vis-a-vis what can be promised. So the choice of procedures could be keratorefractive procedures, toric IOL rotation, piggyback IOLs, and sometimes even YAG capsulotomies for problems that have occurred. So keratorefractive procedures would include LASIK or PRK. First treatment for residual refractive error can be this. And high probability of success is there in achieving targeted refraction, provided the residual refractive errors are really not too much. Now, the limbal relaxing incision or arcuate keratotomy was traditionally used earlier, which was nomogram guided, minimally used, but only thing is it doesn't have very high predictability. So more or less, as far as the premium IOL implantation is concerned, it is not used. The prerequisites for any enhancement that you would want to do is that the refractive error should be stable, the residual refractive error should be stable, and the topography should be normal. And in these cases which go for laser vision correction, the IOL exchange, if it is contraindicated, is generally contraindicated in these cases, and monovision adjustments are often not possible. So basically, if you want to do LASIK, and this is a study which showed that if you want to do LASIK for these patients, it does give good results where the creation of the flap is done by the femtosecond laser, elevation is done, application of the excimer laser on the stromal blade, and flap reposition with irrigation of the interface. People have even tried multifocal femto presby LASIK in pseudophakic eyes, but there are not very many studies of the same, although isolated reports which are available do show good results. This was a review article actually which looked at outcomes of excimer laser enhancements in pseudophakic patients with multifocal intraocular lenses, and it did show that in the studies that were available, the multifocal IOL is safe, effective, and it is laser vision correction is predictable. Of course, if there are problems like posterior capsular opacification, then that has to be dealt with the YAG capsulotomy. Now, at times there may be a problem of the rotation of the intraocular lens, especially if you use the toric intraocular lens, and we do have ORA. I think it is a great tool, especially when you have to see whether the axis is correct or not. And although it is now discontinued, but it does tell you, it does give you NRR, that means when no rotation is required, and this was a case which was referred to us, which was off-centered in fact, and on aura we were able to center it. The patient didn't want a exchange of the lens because didn't want a surgery, so no exchange of the lens was done, only the axis was rotated in position. Then piggyback IOLs can also be done in cases of high residual refractive error, when there's a refractive surprise, when there are extremes of biometry, and they provide toric correction as well as multifocality addition. And this is a case in which the piggyback intraocular lens implantation was done a post-RK patient where there was a residual refractive error which was present. And in this, first the cataract surgery was done, and then subsequently, because of the residual refractive error that was there, post-op day 1, we had a surprise of plus 0.5, 5.5D in fact. So a piggyback IOL was placed on the IOL which was already there. Alternatively, we could have exchanged this IOL also, but in this a custom-made add-on piggyback lens Sulcoflex was implanted, and the post-op results following this piggyback IOL were acceptable and were optimal. And when the refractive error is high, that you actually have to customize it. And so the visual acuity on post-op day 1 itself was 6.6. Now, people have described polysodrophikia from piggyback to supplementary sulcus fixated IOLs, but I think this is taking it to the other extreme. And there are various IOLs which are present, which can be sulcus fixated supplementary IOLs, as has been shown from various companies. Rotational stability of the toric intraocular lens, like I said earlier, and this is again a meta-analysis which shows that toric IOLs of current era have exceptional stability with a mean rotation of only 2.36 degrees, and the materials and the methodology for making them is getting only better. Another problem could be of post-op dysphotopsia, and this Dr. Prakhyat Roop has described new device to treat this negative dysphotopsia, and this paper is again published. Apart from this, reverse optic capture can be done, or nasal optic truncation has been designed, or alternatively you can even change the position of the lens, and it can sit in the horizontal orientation rather than the vertical orientation, where it will cause less amount of dysphotopsia. Now this is the negative dysphotopsia ring which is being implanted. So basically in this the pupil is dilated first, and this is subsequently followed by the negative dysphotopsia ring. This comes by IOCare group, and the material is hydrophilic, and this is put into the injector folded like you would fold an intraocular lens, and then subsequently is implanted over the lens which had previously been implanted. And the idea is that it keeps the bag a little bit stretched, so the reflection of the rays which occurs from the edge of the lens is taken care of, and subsequently the irrigation aspiration of the viscoelastic is done. This has been done in more than 20 plus eyes with good results. Now, so to summarize, I think post-cataract surgery refractive error can be corrected by cornea-based procedures such as excimer laser, options of LASIK or PRK, or lens-based procedures where IOL exchange can be done, or piggyback IOLs can be used. But I think it is important that it should be matched with the patient expectations, and also we need to counsel these patients for the second procedure of enhancement that is done in these cases. And I think pre-op counseling for the second procedure, like in cases of post-RK eyes or in eyes where you expect that this might occur, is the point which is of utmost importance. Thank you very much for your kind attention.
Thank you, ma'am, for comprehensively covering all the enhancements.